Welcome to the University of California, San Francisco Sports Medicine Podcast, featuring Dr. Nira Pundia, Dr. Brian Feeley, and Dr. Drew Lansdown, discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
Welcome to this week's 6 to 8 Weeks with me, Brian Feeley, Drew Lansdown, and Nira Pundia is off on vacation this week. So we're going to talk about things that happen mainly to adults. And today we're going to focus on the biceps. The biceps is something most of us are most familiar with in terms of going to the gym and exercising, but it's also one of those muscle injuries that's actually really common. And we think about the biceps both at injuries that can happen at the shoulder as well as those at the elbow. So we're going to break those down a little bit, talk about what the biceps is good for, what it's not useful for, and how we address these injuries and how we fix them. So Drew, first question, what is the biceps good for other than looking like you're doing something important at the gym?
Yeah, so biceps, it is a useful muscle and past just what you can do at the gym. And the primary function of it is actually in rotating the hand. So the motion called supination, where you turn your hand to where it's palm up, and it's really the strongest muscle that does that. So if you're screwing in a light bulb, using a screwdriver, opening a door, everything like that is using that biceps. And then it also works as a elbow flexor, so to raise your hand up towards the shoulder. And you have other muscles that do that too. So it's not the only one that gives you strength for that, but also does some strength and flexion.
Yeah, I think that's really important in thinking about what the biceps does. The thing that flexes your elbow or bends your elbow so that you can get your hand to your mouth is actually mostly the muscle underneath the biceps. If you put your hand on your biceps and think about this, what your biceps really does is take you from a palm down position to a palm up position. So what I tell my patients when they're trying to figure out, well, how come I don't need my biceps to do what I think it does? I tell them to put one hand on their biceps, put their hand on a desk, and then feel their biceps as they turn their palm up, and you can feel your biceps flex. And I think that's really important. And that goes into, which we'll talk about in a little bit, in terms of how we fix it and where you put it on in the forearm when you're trying to fix these distal biceps injuries. One of the things I think is really interesting about the biceps is that it's actually a really poorly designed structure for us as people that are upright. And most of us, I'd say probably 95% of us are upright. We walk on, hopefully, walk on our legs and use our arms for throwing and for writing. But the biceps actually has two tendons in the shoulder. So can you describe the anatomy? Because I think it's something that most people, even most physicians, probably don't understand.
Yeah, so the biceps starts approximately up by the shoulder, and then it's called the long head of the biceps and the short head. And so those are two different tendons and then muscles that then come together into one. And the short head, so it starts on the coracoid process. So this bump of bone at the front of the shoulder blade. You can kind of feel it on the front of your shoulder blade. And then the long head, it starts at the top of the shoulder socket, the glenoid, and then it travels through the joint, and then it runs in a groove at the top of the humerus, the bicipital groove. And then those turn into, one primary muscle, though still distinct through there. And then there are still two tendons that attach at the elbow, but they are more together versus these two separate origins up at the shoulder.
Yeah, I think it's important as a stabilizer in the shoulder, especially for what we thought at first it was really important for stabilizing the shoulder for throwing athletes. Turns out that might not even be true. But certainly if you're walking on all fours and you don't have that stability from a rotator cuff like we do, it seems to add stability for animals that walk. But because of its anatomy, because it takes such a weird right angle turn and goes through that narrow groove, it's really at risk for degenerating early, as I think anybody over the age of 50 has probably had some biceps pain. But I wanted to switch gears a little bit and talk about the biceps tendon at the elbow. Lots of NFL players have biceps tendon ruptures at some point. It's usually one of those injuries where you're trying to tackle somebody, you get your arm stuck and your arm essentially gets extended and you get an injury at the elbow. Is this the type of injury that needs to be fixed, should be fixed? And how do we do it?
Yeah, so I think the biceps at the elbow, those tendon injuries should be fixed. And the problem is if you don't have that attachment, you really don't have anything that replaces that twisting function, the supination. So you lose, like 40, 50% of the strength in supination with that type of injury. And there are times where you say, well, it's my non-dominant arm. I'm not active. I don't do anything with my arms. I'd rather, just let it be rather than go through an operation and surgery. So that's totally understandable. But the vast majority of times, I think it is better to repair it surgically with the goal of getting back that function, that twisting power.
So I'm going to ask you a trivia question. Do you know the last famous NFL athlete that decided not to get his biceps fixed so he wouldn't miss time? Kind of a Ronnie Lott pinky finger situation.
No, distal biceps at the elbow?
No biceps, yeah.
I don't.
Yeah, so apparently Terrell Suggs decided he didn't want to miss time, so he was going to just play without a biceps. And I guess if you're braced and your arm is all the way up, you can probably play football and get it fixed at the end of the season. But for most people, and I think the vast majority of us are not NFL athletes or not even built like NFL athletes, if this happens, this is something that we're going to want to fix in probably the first 3 to 4 weeks after injury, correct?
Yeah, and I think the biggest thing too is if it's done early after the injury, it's usually a really straightforward surgery. The tendon's off, and then you just reattach it to where it used to be. And then if it's left for a long period of time, it starts to scar in, and there's nerves, blood vessels around it, things like that can kind of complicate freeing that up. So it goes from a very predictable just reattach the tendon surgery to inviting potential for other issues. And then the muscle and tendon can remodel over time too, to where they may not reach back to the same attachment point, which just makes it less predictable too.
All right. So injure your biceps at the elbow, get it fixed soon. All right. So let's talk a little bit about the shoulder, because I think the shoulder is a much more common biceps injury. And we talk about the biceps at the shoulder. We almost always are talking about injuries to the long head of the biceps. The short head of the biceps, I tell my patients, is well designed. It attaches to that bump, that coracoid that you can feel in the front of your shoulder. The long head takes a kind of circuitous route. It's extremely long, hence the name long head. It goes between part of your rotator cuff through a narrow groove, takes a right angle turn, and then attaches in the middle of your shoulder joint, essentially, which is, essentially moronic. It's like being designed to have a breathing tube right next to where you eat so that you can choke and pass away. So when I think about biceps injuries, I think about them kind of in a spectrum where we can get kind of inflammation around the tendon, or you can get tendonitis or tendinopathies. You can get tears at the attachment, which we call slap tears, or you can rupture the tendon. So when you think about patients with biceps tendonitis and tendinopathies, what are the classic symptoms that you usually think about that helps you diagnose this?
Yeah, so usually it's like in the overuse realm. So it's often like, I haven't been swimming, I just picked it back up and I'm doing, that repetitive overhead motion, or like I'm back to the gym after a while away, getting back into everything, and then my shoulder flared up. So oftentimes like a change in activity or increase in repetitions, things like that trigger it. And then usually it's just this pain at the front of the shoulder. And pain with activity. Oftentimes it'll be sore at rest too, but the biceps is running just right at the front of the shoulder. It's usually just pain right in that area. And on exam, we can usually just push right on it, and that's sore. There's a few other tests that we can do to bring about the pain, but pushing right on it's a good indicator that that's the problem.
Yeah, I think it's probably one of the easiest things for us to diagnose in clinic, because it's anterior pain, tends to hurt with things like a push-up, where you can imagine your biceps is stretching over the front of your shoulder. So as you get down in a push-up, or for some of my patients when they're doing things like surfing or getting themselves out of that deep position, they'll localize their pain right there. For swimmers, it tends to hurt right at the front of the shoulder as they're catching the water, and that first pull, because that's where you irritate the biceps. And even for people who do a lot of bike riding, you don't really realize how much you use your rotator cuff in your biceps until your biceps is irritated. When we think about where the biceps attaches at the superior labrum, so we talk about this as kind of a different type of injury. How is that different? And does that really manifest very differently in patients?
Yeah, and the problem is, so it's like almost confluent with the top of the labrum. And then if the labrum tears, then you now have like an unstable attachment of the biceps. And so anytime you're moving the shoulder, there's potential for that attachment to move around, and then that eventually gets inflamed, irritated, and then when it's really unstable, it just doesn't have a chance to, or may not have a chance to really calm down and stop hurting. And it's something that it's extremely common, especially if you look at just at MRIs, like some degenerative change, some fraying, some tearing, and then only I think occasionally can really be the main thing that's causing symptoms. And then it is something that we can often get better without surgery. Even if it is unstable, we can get the shoulder to calm down and then still function well. Even if you're looking at like professional throwers where, we see them pretty commonly that, they have some evidence of injury to the labrum, but can still get them back to throwing without, any drastic surgical measures. But can definitely be an issue because of that attachment point.
Yeah, I think it's really interesting because when we look at MRIs, pretty much everybody over the age of 37 to 40 has some sort of superior labral tear, slap tear. But when you get the MRI report, it looks horrible. It says severe degenerative changes with detachment of the superior labrum at the biceps attachment. And that sounds like your arm is about to fall off. And in reality, if we were to put a camera inside most people's shoulders, it actually looks pretty okay. And what we see on MRI looks really, really benign in most people. When we look at people with biceps tears, especially when it's starting to actually tear, either within the groove or especially in that area within the shoulder joint, it really is torn. So imagine like a rope where half of the fibers are torn, the other half are just hanging on. Those are ones that we tend to want to fix. And can you describe how we typically fix those, or what's called a tenodesis?
Yeah, so either a tenodesis or the other option is just a tenotomy, where since you have two tendons, we can actually even just release the long head. And then the other option is to release it and then reattach it on the arm. So like you said earlier, that tendon is really long, and the muscle starts, in the the mid arm, just right by where the pec tendon is. But so we can take that tendon, release it from the shoulder joint, and then just plug it into the humerus further down the arm. So it's still in the tendon, it has an attachment point, but it just now doesn't go, up that course into the groove and into the shoulder. So it can still work. You can still have the same function, the same muscle length, everything else, but it just doesn't have that long, irritating course that it takes.
Yeah, I think it's one of those things where when you first describe to patients, they're like, you're crazy. Why would I not want this fixed? So I'm going to ask you a trivia question. Can you name 2 Hall of Fame quarterbacks that had a proximal biceps rupture that did not have it fixed?
So I know Brett Favre had biceps tenotomy because he wanted to come back and keep playing and didn't want to take the time off for rehab.
That's one.
And let's see, that he's probably enough because he counts as like 5 quarterbacks.
Yeah, so the second one, at least according to the internet, is John Elway, and it's often the same thing. So he said, he ruptured his biceps, and what they said was, Broncos doctor said at the time of the injury, there was very little necessary biceps function involved the way Elway threw the ball, or honestly, the way anybody threw the ball. So it was quicker for him to get back on the field if he just didn't have surgery. Now, the reality is sorry, are you going to go on about Wrangler jeans and copper
no, but
Brett Favre?
John Elway also played without an ACL.
Yes.
Yeah, other interesting trivia about him. So pretty good career.
As a Stanford alum, you learn that John Elway, other than not having good dental work as a kid, actually tore his ACL in high school, apparently, and then was rumored not to be fast enough. So doctors decided you probably aren't going to need that. So he tended to do pretty well.
Yeah.
I mean, there's no Steve Young, but so my last question is that, we talk a lot about biceps injuries and we talk about surgery where we either fix it or don't fix it. What percentage of people with biceps tendonitis do you think actually need surgery?
Oh, I'd say very low. I mean, maybe 5%. I think it's something that we can almost always get better without surgery. And usually it's just, good PT program. Mostly it'll be backing off those aggravating activities just for a time to let it calm down, and then coming back with good mechanics, good strength, and then hopefully it's not happening again. And then we can do like injections, that can help calm it down. Those can work really well too. And then, it is a good surgery. It works really well if nothing else is, but I think it's one of those ones that for most people, just going through the surgery, the rehab, the recovery, all that's more than, just getting it better on its own.
Yeah, totally. Yeah, I think in general, my first advice for patients is figure out what the aggravating activity is. And it's something that you did 1 or 2 times that you can modify. So for me, when I've had biceps tendonitis, it's almost always exercise at a hotel gym or a gym I wasn't familiar with, and a machine that irritated the front of my shoulder, rest, and then recovery, anti-inflammatories, physical therapy. If that doesn't work, in a steroid injection, patients are often worried, well, it's going to mask the pain and then something bad is going to happen, or I'm going to rupture the biceps tendon. The reality is a steroid is going to decrease inflammation and make you feel better. And if a single injection around your biceps is going to cause the biceps to rupture, it's probably going to rupture anyway.
On its way out.
Yeah. And then the final thing is surgery. And I totally agree with you. It's a great surgery. It works really well for a majority of patients. And I've even had a few patients where the biceps was really unhealthy. We did the tenodesis, or we reattached it, and then it kind of autotenotomized, meaning the whole tendon wasn't healthy enough, and it didn't maintain its fixation. And those patients are usually quite happy, mainly because their rehab all of a sudden goes faster.
Yeah. Yeah. And I think the big thing is at the shoulder, like lower chance of surgery for sure. And then at the elbow, almost all of them should be, I think they're best treated with fixing it surgically.
Yeah, totally agree. All right. Well, thank you for joining us today. Hopefully this was informative and more than you needed to know about the biceps. Maybe next time we'll talk about how Drew exercises each head of the biceps individually on 4 separate days.
That'll be more than 20 minutes.
All right. Thanks, everybody.